It's a pleasure to be here, and thank you for the invitation. And I do want to acknowledge Dr. Madeline Cunningham, my co-founder, who is not here. Her research work probably spanned maybe 20, 30 years or so, including that with collaborating with Dr. Sweeto. And the basis for the underlying test and the targets that I'll talk about today have to do with that research, and then further talking about the things and the studies that we're doing at the company. And Dr. Cunningham remains a professor at the University of Oklahoma at the Health Science Center and conducts additional research there. I did want to acknowledge, I don't know if Dr. Sweeto is still here, wanted to acknowledge her as being the pioneer of a movement that really is something that, even though there may still be what we might think of controversy in the academic world, the practical matter is that she's impacted through this literally multitudes of lives. So at the forefront, and being a transplant from California into Oklahoma over 30 years, I'm an Okie now. My family says I have a Southern drawl. So I've learned what a pioneer really is, and pioneer has arrows in their back. So Dr. Sweeto, you're a true pioneer, but more so, yes. Like maybe 3 decades ago, where we knew about peptic ulcers, and it was kind of mentioned that maybe it's caused by a bacteria called Helicobacter pylori. And the medical community really did not believe it. And fast forward to today, it's pretty common understanding that you have a peptic ulcer, you get tested for this, you get an antibiotic, and you go home. And I do truly believe that as science and medicine continues to evolve and research continues to grow, as was mentioned earlier, that I do believe that these conditions, PANDAS and PANS, and I do believe that it's a medical model for other conditions, just like Sydenham chorea is a medical model for PANDAS and PANS. So I do have one disclosure. I am the president and CEO of Moleculera Labs and an employee of the company, of which we perform the Cunningham panel, and I don't have any other disclosures. So what I thought we would cover today is really an overview of a survey that we had recently conducted to look at the economic and psychological costs of PANDAS and PANS. We're working on a pharmacoeconomic model, and we're looking at least to try to provide some supportive data that would look at what really is the impact of this disorder on families and also on society, because as we know that many of the insurance companies and many of the other organizations that are involved have to do with cost containment or cost, whatever they call it, but some places call it cost efficiency. But if you look at really what is the cost, I think find that it actually is less costly to treat it. We'll talk a little bit about molecular mimicry, the role that infection-triggered autoimmune disorders play on the brain. And then lastly, I wanted to share with you a bit more about the underlying biological basis of the test, talk to you about a population study that we're getting ready to submit as a manuscript, and then some broader-based studies that how this might impact other disorders. So the economic study that I'd like to share with you is something that we put together. Amy actually spent a lot of time here. Amy Cross, our nurse in the back here, sitting very dutifully back there in the table. We have in our database over 2,000 patients who had given informed consent with their test. Today, we've actually tested over 7,100 patients around the U.S. and around the world. So from June 12th, 2018 to July 16th, about over 1,000 patients completed the survey, and we thank the PANDAS Network, who also helped send this out. It did spread around, and over almost 6,000 individuals had taken a look and tried to complete parts of it. But we asked 56 questions, and we wanted to find out what was the final financial impact, we wanted to find out what the social impact, and to quantify some of the data that was involved in what do parents go through. Shouldn't be talking to you, she should be telling me, but I do have even some employees who this has been affected and relatives of employees. So one of the questions was, how long did it take to get any type of treatment, medication, or therapy for your child after he or she was diagnosed with PANDAS or PANS or autoimmune encephalopathy? And what you can see here is can be anywhere from 1 to 3 months to greater than 5 years. Another question, and I'm only going to share a handful of these questions. Please estimate the total cost of all medications, supplements, and special foods purchased to meet prescribed dietary requirements related to your child, PANDAS and PANS. And I'm going to change my glasses because I'm actually over 60. So, yeah, and the print is very small. And the bottom do not include the cost of IVIG or plasmapheresis in the total estimate. And what you can see here is anywhere from $1,000 to over $50,000. And that doesn't include the IVIG treatment or plasmapheresis. Other question was, did your child's insurance cover any of these costs related to immunotherapy treatments or therapies related to his or her PANDAS, PANS, or autoimmune encephalopathy diagnosis or symptoms? And you can see the vast majority said no, but some of them said yes, and we find that it's probably partially covered. The other was, has this financial impact of your child PANDAS or PANS or autoimmune encephalopathy diagnosis or symptoms caused you to do any of the following? And these were a few questions that we had asked. And you can see from here a whole host of different responses. A lot of them have to do with borrowing money, credit card debt, sell personal valuables. And because we gave an open invitation to add to those responses, there was almost 200 other comments that came. And you can see these comments here: broke and in debt, sold house and bought cars, skipped bills, we're close to declaring bankruptcy, find a part-time job, loss of income when ultimately had to stop working, borrow from a high-interest lending company, et cetera, et cetera, et cetera. And so these are just a handful of the responses. And I'm sure all of you who have a child with PANDAS and PANS can relate to this. And so if there were legislators here today, we would applaud them for Illinois being one of the first to adopt those laws, and certainly Wendy and your group for being able to pioneer those. And we hope that that continues to happen across the country. So how do these challenges really come about in medicine? You think, the United States is one of the most sophisticated scientific medical countries, spending, 16 to 18% of the GDP in medicine and healthcare. Why is it that some of these things sometimes baffle us? Well, if you look at the prevailing understanding of disease and biology, the thought process is that disease and disease categories are separate, they're separate entities. And if you see how medically trained in the medical schools is that these are specialties in different disease disorder, or rather organ functions that correspond with some disease disorders, when in reality we know that the existing and evolving view of disease etiology is that these actually overlap. We know that the gut is involved with the brain, and that the immune system is involved with the gut, and infectious diseases are involved in all of that. And if you think about medicine and PANDAS and PANS, you see that it crosses infectious disease, crosses psychiatry, crosses neurology, immunology, rheumatology, and then you've got adults and children. And so some of this is the method in which we approach disease. And I believe, because of other pioneers and those that are out there, that this will eventually migrate and change also. So the other challenge in neuropsychiatric disorders, as you've heard and is that they're typically categorized as either being ruled out of something else and classified based on symptom and behavioral symptoms. So you can see many of these symptoms up here, whether it's motor tics or repetitive behavior, hyperactivity. I recognize difficulty in school, but I didn't have an autoimmune condition. separation anxiety, inability, aggression, rage. And then there's a handful, but there's a lot more of these categories that patients get placed into, and well-meaning. And when they get placed into these categories, oftentimes what's believed and understood or thought is that these categories then are incurable. And so what we find is that based upon sometimes previous diagnoses, then it becomes more difficult for you as a parent or someone to get their child treated for something known as maybe an autoimmune encephalopathy or autoimmune neuropsychiatric disorder of the basal ganglia or PANDAS or PANS. And so it becomes a bit more difficult to try to get that label taken off. So one of the simplistic mechanisms, and as Dr. Sweeto mentioned, many more immune system components, is that we all get infections, whether it's viral, bacterial, fungal, and the nature of how we were created is that we have an arsenal of an immune system that recognizes these as foreign. And as it does this, it identifies them and makes ultimately antibodies to attack and destroy these foreign invaders. But in some patients, and we'll talk a little bit more about maybe some of the genetic susceptibility, is that these antibodies that those patients make actually end up cross-reacting with neurologic receptors. And we call that molecular mimicry, and hence the name of the company, Moleculera Labs, is because if you think about the protein alphabet, there's only 24 letters in the protein alphabet. And so organisms like bacteria and viruses and other proteinaceous infectious diseases, they also have to use the same 24 letters of the alphabet. And at some point, there's some homology between those letters in their alphabet and our letters in our alphabet. Now, the immune system is trained through its surveillance system to not let those cells, T cells, B cells, be created and let out. But in patients, in some patients, those B cells and T cells and plasma cells get allowed and get let out. And once they're out there, they're called memory B cells, and they continue to produce antibodies. And it's similar to why we get vaccinations with attenuated viruses, because you want to train the immune system to see it as foreign, create these B cells that have memory, and therefore, if you in later in life get exposed to something, you don't have to wait 6 weeks before your body begins to make antibodies against this particular disorder. Well, in these patients, what happens is these particular antibodies cross-react with different neurologic receptors in the brain and in the CNS, and sometimes we call this friendly fire. And if you think about the wartime, where we accidentally maybe target our own troops because we couldn't tell the difference between the enemy troops and our troops, but one of the strongest systems in our body, which is the immune system, begins to direct attacks against us. And in reality, this is not an uncommon situation. If you think about, this happens and they began to attack our joints, we call it rheumatoid arthritis. If it attacks our pancreas, sometimes we call it diabetes type 1. If it attacks our thyroid, we call it Hashimoto's. But what about if it attacks the brain or parts of the central nervous system? Do we call this mental disorders? Do we call it rebellious kids? Do we call it bad parenting? What do we call it? And what are those things that actually occur in order to be able to identify and understand that? And so what does happen, unfortunately, is these different types of syndromes and different types of symptoms occur. And in doing that, many of the standard therapies is then to treat it as a anxiety, psychiatric, neuropsychiatric disorder. And those are very helpful because there's over 60 million people in the US who are on some form of antipsychotic, psychotropic, anti-anxiety, antidepressive. And so these are very effective. But in patients whose etiology is an immune dysfunction, these are not. So as we talked about molecular mimicry, and we talked about, Dr. Sweeto talked about the work of Dr. Cunningham, the strep and group A streptococci have a particular letter alphabet that's very similar to various parts of the body. So the group A carbohydrate, which allows the recognition for the type of bacteria, also has an M protein. And that particular protein has homology in conjunction with different parts of the body. And so you can see it in the heart, hence rheumatic fever. You can see it in the brain, certain choreiform movements. You can also see it in the kidney and certain other parts of the body. And this is something that is actually well understood and known. And molecular mimicry is not something that's totally new. In fact, if you look at Guillain-Barré syndrome, it's understood that it's triggered by a Campylobacter jejuni infection. Other infections actually have that, but that tends to be the most common stomach infection. And then the antibodies began attacking parts of the myelin sheath. And so, what's the connection there? And if you look at the molecular level of these different organisms and the parts of the myelin sheath, you can see part of the carbohydrate and part of the protein that's virtually identical to each other. Normally, our body says, don't make that because that's me. But in the cases of this is where Guillain-Barré occurs, and also immune modulators are known to be effective. In fact, there's a good paper there by Cusick that you can find a whole host of other different disorders that have been identified with molecular triggers that have actually triggered individuals to begin making antibodies against certain of these different targets. And so it brings us really to a bigger understanding of, rather than a disease category based on symptomology, can we understand and identify the etiology of disease and treat the etiology rather than classify the different types of subdisorders and treat those as if they're separate entities? And in fact, what we're finding is that, and I'll share with you a paper, patients who actually were diagnosed with autism but actually had an autoimmune etiology. And as you can see, half of epilepsy is actually even known to be autoimmune because they don't respond to standard epileptic medications. Now, again, this is not to say that everyone with the motor tic or everyone with OCD and all of these are due to an autoimmune etiology. But again, if you look at etiology versus looking symptom classification or at least categorization, then we can actually treat the underlying root cause, which is actually the basis for precision medicine, to identify what it is that actually is wrong and then target to the disorder. And what we believe and what we find is that there's a number of things that have to happen and come together in order for an individual to get PANDAS or PANS or any of these other autoimmune disorders. And I like to look at it as an axis, that you have these infectious triggers, and in cases even non-infectious triggers, but they can be environmental, bacterial, viral, parasitic, and what you then see is the involvement of the immune system. Whether it's autoimmune antibodies, microglial activation, other types of cytokine disorders, it still is the immune system that's involved. And then the connection between the immune system and the recognition of homologous proteins in the brain or the CNS. But underlying that, as Dr. Sweeto mentioned about Dr. Frankovich's work, about the genetic understanding of these HLA genes. And so they're not patients that have family history of genetic disorders, of psychiatric disorders, but they're actually immune system dysfunctions. And what we find is that in many of these patients, you can identify some history of some form of immune dysfunction in the family line. Doesn't mean that they will get these conditions, but if these other things happen in some type of combination, that they will actually then begin to cascade and progress. So I'm going to talk about the autoimmune and anti-neuronal antibodies, and these are not new either. There are other anti-neuronal autoimmune antibodies that are published out there. And as you can see from this publication, you can see that they do attack different parts of the nervous system, different parts of the pre- and postsynaptic nervous system. But as you can see on the left side, the study that they did, they had identified patients that had an autoimmune etiology from imaging and other factors, and yet they could only account for half of those with these current autoimmune anti-neuronal antibodies. And so what that meant was that there most likely were other types of antibodies targeting different receptors that actually were involved in some of these disorders. And so that's actually what we're finding to be the case also. And as I mentioned, there are two publications that just were printed in last month. A group of about 82 autistic patients who, a subset, had an autoimmune etiology. And Dr. Richard Fry had published this just last month, that he treated those subset of patients, about 30 plus of them, with IVIG, and he also tested all these other anti-neuronal antibodies and tested the Cunningham panel. And then he monitored them over 2 years, and he found that the antibodies that the Cunningham panel were actually targeting were the best predictors of those patients that responded, at least in his study. And so with 90% response rate through ABC scores and other autism standardized treatment scores, he was able to identify that. The second one is a physician from Cincinnati Children's. There was a 15-year-old girl who was diagnosed with schizophrenia, in and out of the hospital 3 or 4 times. They called in then an immunologist who then ran the panel, Cunningham panel, and the patients had high titers of these autoimmune antibodies. They treated the patient, in this case, I believe it was with plasmapheresis, and the patient is back at home playing tennis and going back to school and off all psychotropic meds. Now, is that to say that schizophrenia is going to be cured by IVIG or plasmapheresis? The answer is no. But again, if you look at what the etiology is rather than what the symptom classification is, in this case, it actually was a patient that had an autoimmune encephalopathy or an encephalitis. So as we talk about the panel itself, just want to show you the report. There are 5 different markers, and actually there are 4 targets in the brain, and those 4 and in the nervous system. The other is actually a stimulation assay. It's involved with growing up human neuronal cells in culture and then incubating the serum of a patient on these human neuronal cells and then pulse chasing them with P32. And the reason that we do that is because the enzyme called CAM kinase is involved in a high order regulation of cell plasticity, but the other is it also upregulates the synthesis of 3 neurotransmitters, dopamine, epinephrine, and norepinephrine. And some clinicians who have run lots of tests have identified subsets of different types of symptoms that they've been able to categorize in which ones are positive. We're still looking through these with the 7,000 patients that we have. And as you already saw this slide from Dr. Sweeto, it's Dr. Cunningham and her, who had published in Nature Medicine and Journal of Neuroimmunology, that these antibodies also cross-react and target those parts of the brain from PANDAS patients, from Sydenham, Korea's patients. And then the other really great finding was that they cross-react, and not only they cross-react, but they cross the blood-brain barrier. And so there's different mechanisms, but as you heard earlier, one of the ones that was not unknown is that passageway between the olfactory nerve. So as you also heard earlier, is the specific portion of the brain is this basal ganglia. And it is involved biologically, and that's well known, to control voluntary motor movement, hence the tics, procedural learning, also cognitive function, emotional function, and even interestingly, eye coordination. And I think one of the symptoms that you see in PANDAS and PANS patients would follow suit. The 2 disorders, just for information, that are known to be basal ganglia disorders are also Parkinson's and Huntington's. So what we also find, and again, this is not a prospective study, but it's the clinicians who report to us, they tend to find certainly group A streptococci very frequently, but they also find that there may be, and in cases that they find that they may have 1 or more infections. And if you think about it, it's a kind of a logical thought, because if you have an immune system that's not functioning properly, of which you would be susceptible to various types of infections that your body's normal function would take care of. And I use the illustration of HIV, which we worked on back in '83 to try to develop a vaccine, which is still not existent because we didn't know anything or virtually anything about the immune system, that they don't really die from HIV. They actually die from infections that you and I come in contact with every day. It's because their immune system itself is not functioning properly, and that the virus now is understood to attack the very core of the immune system, which allows itself to be able to be unimpeded. So I'll go through some of the different tests and talk a little bit about the biologic function. The human dopamine D1 and D2L receptors, there's actually 5 different, at least known, 5 different dopamine receptors. And the D1 and D2 are highly concentrated in pre- and postsynaptic neurons in the brain. And we use a specific kind, and we look for them, and we use them in targeted assays and look for serum antibodies that cross a threshold upon a certain baseline normal level. What we find also is that not only do they just bind to them, but they can act as agonist or antagonist. And so a patient that might have an antibody against dopamine D2, for instance, it's not just that it's the antibody against dopamine D2. It could act and bind to it, but may not impede its function. It can act and bind to it and actually act as an agonist, meaning it functions as if it was dopamine because it binds into the active site of the receptor, or it acts as an antagonist, and it binds and it blocks the function of the receptor, so dopamine can't be utilized properly. And we see this the case in patients. We don't do that assay in the clinical lab because it's too tedious and would cost too much. But in the research side, we're able to identify that this is the case. And so one of the sort of surrogates is, does it bind to D2 or D1? Because you really don't want to see high titers against those particular proteins in your body. The other is tubulin, and tubulin used to be just thought of as sort of a biological bystander, but it is now known that tubulin plays an important role in cell signaling, communication within the cell and the brain. And in fact, studies have been done that if you look at mutations or deletions in certain parts of the tubulin, that you can also see that you end up with OCD, cognitive impairment, different types of symptoms, and you can see all of these different symptoms in patients that have genetic mutations in the tubulin gene. So what we find is it's not only highly concentrated in the brain, but it also plays more than a role than just scaffolding in a cell, which is what originally was thought of. But it's involved in meiosis and mitosis. It's involved in other functions of the cell. So it's an integral function and a protein that if it's disrupted, and you can see these tubules, they're made of alpha and beta subunits, that they self-assemble. And in order for them to self-assemble to do their function, they have to be able to recognize each other. So if antibodies are interfering with this self-recognition, then you can see differences in their ability to be able to self-assemble. And you can see in the neuron slide that these are antibody staining tubulin, and you can see them in the neuronal cells. Lysoganglioside, in particular, GM1, because lysogangliosides, there are many different kinds. Some of them are around the myelin sheath, and as you can see, it's a carbohydrate function with also a moiety at the end. And again, I mentioned that Guillain-Barré syndrome is also one that has anti-lysogangliosides, but it has a biological function to insulate the nerve pathway. And so as a nerve impulse goes down through from nerve to nerve, it has to be insulated, kind of like an insulation around a copper wire. If you remove the insulation from a copper wire, you don't get faithful transmission of the electrical current because it gets dissipated. It's one of the thoughts of how this actually happens in other types of similar disorders that attack the myelin sheath. You can think of multiple sclerosis and other types of conditions, and they affect different types of movement. And then last, as I mentioned, the CAM kinase, these antibodies, it's now being more understood that this enzyme is very critical. If I showed you the pathway up here, it would look like a Los Angeles freeway. So there's all kinds of different interactions with this enzyme, and it's responsible for many different functions. And as you can see here in both Sydenham, Korea, and PANDAS patients, that they're elevated but at different levels. And so what we find also from genetic studies in these two papers, the one of American Journal of Human Genetics and in this other paper, in loss of function mutations in a CAM gene, which would translate to an inefficient or dysfunctional enzyme. And you see here what they say is variants in the latter genes may cause, excuse me, intellectual disability, infantile epileptic encephalopathy, epileptic aphasia, or be associated with Tourette syndrome, schizophrenia, or autism. Functional studies performed in this study suggest that CAM2A and 2B, these are two subsets, may be involved in a broad range of neurologic and psychiatric disorders. In fact, they're seeing that mutations in those actually end up with many of these similar disorders. Okay, I'm going to speed up here. The case studies here, I'm going to show you a couple. We now have over 200 of these, and what we want to do is at least just show some representative sample. This is a patient, a 9-year-old male who had 30 days post-strep infection, OCD tics, and what you can see is one positive. It was in the CAM. And the reason we do the 5 is because we don't know which ones they're going to be responsive to. That patient was treated with IVIG 1 month after diagnosis, complete symptom elimination, and we retested him, all his antibodies returned to baseline. A 9-year-old girl who had obsessive compulsive behavior, stimming, sensory motor abnormalities, also bedwetting, dysgraphia. In this case, she had 2 of the 5 positive. This is one of those cases where it caught with strep early on. Patient was treated with azithromycin, rapid improvement, and you can see all 5 of those are back into baseline. So we have over 200 of these, and we're collecting these and getting ready to try to submit these as a manuscript. This is the overall positive rate within, at least in the early part when we had about 3,000 specimens. You can see that they vary in percent frequency positive, and that's because symptoms vary. And the other is, this is why we run all 5, is because we believe also that there's, and I won't have time to go into it, but there's a transition from certain activation to other types of targets. I'm going to quickly go through this. This is going to be submitted to a manuscript next week. We looked through the patients that had 2 or more tests in our cohort, and we identified 62 who had given us informed consent. We identified from the patient and the physician whether the patient improved after treatment and that they had a post-treatment test. And then we analyzed these tests. You can see the symptoms just very correlated. There were PANS and PANDAS, and the symptoms correlated very nicely with many of those that are published. We also then looked at the pre-treatment of all 5 tests. The heat map there indicates the degree of positive level. You can see all the patients had 1 or more tests positive. In the group 1 that recovered and improved, post-treatment, you can see that of those that recovered or improved actually had a great reduction in the number of tests, and it was statistically significant, and you can see that in this number of tests positive. In group 2, those that did not improve for whatever reason, not all of them actually had positive tests, and some of it we believe that there may be other markers, but the other thing is they do take a while to come up. So post-treatment, even though they did not improve, you can see many of them started to show antibodies. And of course, they also did not improve. Their number of tests positive for each panel actually either stayed the same or went up. And there was no statistical difference between the ages or the time between tests between group 1 or group 2. And so you can see the overall number of tests and the titers of all of them. The top group that improved is statistically significant. Even as an aggregate, you can look at the bottom that there was no statistical significance in the difference between those two patient groups. The other is a CAM stimulation assay. We also saw that overall, the group of them that improved did reduce. The group of them that did not reduce. One of the things that we are working on is that we believe that there are other antibodies. We have over 7,000 specimens with about half of them with an informed consent. These are targets, and these aren't the full list of targets, but we believe that there are patients that we may be missing, and they may have other symptoms. And so if you look at the list here, serotonin transporters, serotonin receptors, opioid receptors, muscarinic acids, and then you see different enzymes that are involved in this, like the CAM kinase. We believe that there are targets there, and this is one of the grants that we are working on, is to identify and do high-throughput screening of these 7,000 patients and identify what disorders that these might go with and what symptoms they might go with, and then develop treatment algorithms that might identify the correlation between the patients that improved and what those treatments were and what their current score was for a particular test or panel of tests. And I'm just going to take a moment to go over, because science is science and people publish and it's important that we do that, sometimes studies don't always come out the way that we would like them, as you heard about one with an IVIG trial. One of the Swedish papers that was published talked about using the Cunningham panel in a group of patients in which they tested and retested. And what they concluded that the test was not reliable because they were getting not only positives and controls, but they were also getting inconsistent results in repeat tests. What we did find out, and we did let them know after it was published, that the tubes that they were used contained excipients that were invalid in our study, and those excipients actually interfered with the assay results and the reproducibility. So they published this core agendum. But they still maintained that what they had concluded was still valid. So in this paper that we're getting ready to publish here, or at least submit, what we've done is we've identified, I'm going to go through, skip that the assay is reproducible because we can get plus or minus 1 standard deviation on all the assays. We can also reproduce this over 300 days. But even more importantly, it was the controls. And the selection of the controls were different. The normal range that we had selected that was sent to by the NIMH and also the Yale study, the Yale childhood study, no lifetime history of neuropsychiatric disorders, no first-degree relative with neuropsychiatric disorders, no patient history of autoimmune diseases, and no active infections or symptoms. And if you look at what we did was we took their patients and their disease patients, and we compared it to our controls, and we indeed see that there was really no difference between the studies that we published in their disease patients and looking at the controls compared to that they would fall back into the right range. It's not to say that maybe some patients that are quote-unquote normal might not have an infection that could trigger this, and this is what we would like to find out. But generally, you're not going to treat or test a patient who is not asymptomatic. But I would say that this is certainly the case when you look at biology and try to find what's new and what's going on, that you're going to get these types of things. And I think it's good just because it makes us study a little harder, try to find out what's going on. And there's a few books in the Brain on Fire, which was the NMDA receptor, which is another anti-neuronal antibody. There's a published book now by a psychologist or psychiatrist rather in the UK called The Inflamed Mind, talking about depression, chronic depression, saving Sammy, obviously. And I could share with you a lot more of the research that we're looking to do, because what we actually are hoping is that by understanding the targets of this disease, that we can identify new and better drug targets that we can develop or assist drug companies to develop that would be more specific than IVIG and also less expensive and maybe more targeted towards this, which is really the goal of precision medicine. And with that, thank you for letting me be here. I appreciate your attention.